I welcome you all in the Gemas masterclass. Today, the subject for masterclass is case-based discussion on management of hepatocellular carcinoma. The faculty for this meeting is Dr. Akash Shukla from Mumbai, and the participants in the panel and in the moderator is Dr. Jayanto Mukherjee, who is a senior consultant gastroenterologist in ILS Hospital, Kolkata, and Dr. Manoj Jain, who is a consultant interventional radiologist of AMRI Hospital, Salt Lake, Kolkata. And we have a medical oncologist, senior oncologist, Dr. Saroddat Mukhopadhyay, who is attached to AMRI group of hospitals. And we have a surgeon, Dr. Ramdeep Roy, who is the head liver transplant and hepatopancreatobiliary surgery, Institute of Gastroscience and Liver Transplant, Apollo Hospital, Kolkata. Uh, the moderator, initially it was Dr. Mohandas Mallar. He could not attend because of his personal problem. So I requested my colleague, Dr. Jayanto Mukherjee, to moderate the meeting. And Dr. Akash Shukla has because of his some commitment, he is joining with a within few minutes. Before that, I am requesting Dr. Jayanto Mukherjee to start the meeting with some discussion on hepatocellular carcinoma till Dr. Akash Shukla can join with us. Dr. Jayanto Mukherjee, please.
Has Manoj joined?
He has not been able to join. There is some issues. So you can start with the discussion with Dr. Saroddat Mukhopadhyay and Dr. Ramdeep Roy.
Okay. Basically, what hepatocellular carcinoma is in general is it's a tumor of the liver, malignant tumor of the liver. Usually comes on a background of a cirrhotic liver, but rarely can happen on a normal liver too. What we as gastroenterologists and physicians are more worried about is how early we can pick it up. So therefore, the treatment protocol and treatment options are very many in the early stage, and they gradually diminish as the tumor progresses or the liver gets more and more bad. The commonest diseases which leads to liver tumors are usually hepatitis B and C, which we are very commonly aware of, and rarely what we are seeing it is on a background of non-alcoholic fatty liver disease too. So it manifests as a space-occupying lesion in the liver. As I mentioned, the earlier we pick it up, the earlier we go in for a treatment. The symptoms may be either related to the liver function, which is a cirrhotic liver having a decompensated by ascites, jaundice, pain abdomen, or it can be due to the tumor as a space-occupying lesion as pain and metastasis. So what I would like to, if Manoj has joined, what we would like to know is what would be the initial radiological evaluation apart from biochemical, which we commonly evaluate alpha fetoprotein. But as a radiologist, what I would like to know from Manoj, if he is available, is what are the radiological options he has for a confirmatory diagnosis apart from biochemical and biopsies. If Manoj is on the screen, otherwise I may ask Dr. Sridipta Ghosh to put his views. Dr. Ghosh, please.
We can't get his audio yet.
Yeah. I think the best thing to diagnose a hepatocellular carcinoma in a case is a triple phase CT scan. And if we see a characteristic triple phase CT scan finding in a liver, then we can definitely diagnose hepatocellular carcinoma. And in our guideline also it says that if we say the characteristic finding, then we do not need a biopsy. If we see a characteristic finding and there is a raised alpha fetoprotein, then we can diagnose hepatocellular carcinoma. The problem happens in many of our cirrhotic patients who has got a raised creatinine level. So there we cannot do the triple phase CT scan. Then we have to depend on diffusion MR to find out whether he has got a hepatocellular carcinoma. And then CT scan not only diagnoses hepatocellular carcinoma, but also it gives us an anatomical view exactly where from it is arising, and it will guide us also whether there is any presence of any satellite lesions, because I think our surgical colleague will highlight his regarding the resectability of hepatocellular carcinoma, depending on the size of the tumor, depending on the number of satellite lesions, and the liver uh, function. Now, another thing which helps us in triple phase CT scan, it also gives us a good idea about the feeding artery. In many of our patients, when the patient is coming to us and when we are doing diagnosing this hepatocellular carcinoma, it is maybe not in the stage of liver resection. And then we are thinking of other radiological modalities. And there also, we need to find out that how we are going to plan it, whether the test is applicable or not, whether there is any associated portal vein thrombosis presence or not, and what is the liver architecture and the size of the portal vein and other issues. I think this is my take on the hepatocellular carcinoma, diagnosis of hepatocellular carcinoma from a radiological point of view.
Okay.
Yeah.
One minute. Dr. Manoj has joined us.
Okay.
Dr. Chaudhary, Dr. Shardat Mukherjee, please.
Yeah. I should take this opportunity to highlight one thing, that although it's almost a foregone conclusion that we usually do not require biopsies for diagnosis and confirmation of hepatocellular carcinoma, but there are certain clinical scenarios when there is a requirement of biopsy. I think this should be highlighted.
Yes.
I think the most common scenario is if there is no background of a chronic liver disease, that is a non-cirrhotic patient, and it has a classical radiological feature. Say, for example, a patient who has no cirrhosis, not even the hepatitis B, C, NASH, or NFLD, or cardiac cirrhosis, or hereditary telangiectasia, whatever might be, there is no background, but still the radiologist picks up a lesion which has a characteristic arterial hyperintensement and a portal venous flush out. So in that case, there should be a biopsy done. The second case is that there is a background of cirrhosis, but the lesion we see in the radiological picture doesn't have the classical arterial hyperintensity and venous flow. That's the opposite. We have a cirrhotic background, but we don't have the classical radiological picture. Thirdly, if there is a patient which has a high CA 19.9 and a high CEA, why? Because there is a component or there are a certain number or small frequency of patients we find out which have got a feature called combined hepatocellular carcinoma and intrahepatic cholangiocarcinoma. Just a few days ago, myself and Dr. Manoj, we were discussing about this issue, that there is a very small percentage of cases which has got a CHCC, what we call a combined hepatocellular carcinoma and cholangiocarcinoma. In those cases, there can be a raised CA 19.9 and a CEA as well. Now, depending upon the division of the combination, say if it's about 70% HCC and 30% cholangiocarcinoma, we might get a classical radiological picture. But on the other hand, if the cholangiocarcinoma component is higher, we don't get the classical picture. We were also discussing that there is a way to rule out in these cases of this. So the biopsies requirement is there in the third scenario, where I might suspect a combined hepatocellular and a cholangiocarcinoma. So these are the 3-4 areas or issues where we do really need a biopsy, because in majority of the cases we don't need. Joanto.
Okay, Manoj has joined us. Manoj, what we were discussing is basically in your armamentarium, starting from ultrasound, CT scan, MRI, which one would you prefer to use as a first modality of evaluation for a hepatic SOL?
No, I think, am I audible now?
Yes.
Yeah, you are very much.
Yeah. So now the issue comes from the point where we need to first suspect hepatocellular carcinoma in the background of cirrhosis. Now we are talking in the background of cirrhosis, Hep B, Hep C, whatever exactly it is. Usually ultrasound is first modality which is being done. But once you have a suspicion high, whether you pick it in ultrasound or not, The next modality which you need to do is any of the cross-sectional imaging, which is either CT or an MR, depending on the availability we have in different centers. What typically go in for a triphasic CT or triphasic MR. Now, this is a conventional thing. Now, what is happening is now we are seeing a lot of screening is going up. We are trying to pick up a lot more patients with early SCC exactly. Now, it is here where the problem comes with CT, triphasic CT or conventional triphasic MR. So in last few years, we added another contrast, which is called hepatic specific contrast agents. And now these agents are very sensitive in picking up very early SCC, even in a high-grade dysplastic nodule can be differentiated from a dysplastic nodule. And this is here we can treat the patient or pick up this patient pretty early exactly. So these are scans which are done like a conventional MR, but contrast agent is a different agent, and it's there are only two agents available in the market. One is available in our country, which we are using of late, and we are seeing pretty good result in picking up early SCCs. Now, this is an issue because if you have a larger lesion or background of cirrhosis, it is bound to be HCC on all otherwise, even if you have a classical features or not. So this is another point I would add was, of late we have availability of hepatic specific contrast agent, and this is used in MR, where we can pick up patients pretty early at the stage of high-grade dysplastic nodule or even early SCC, which will not be picked up by a conventional triphasic CT or to a certain extent MR exactly. This is what I meant. So as of now, if you say, if I want to pick up an SCC in the background of cirrhosis, early SCC, I will say it's MR using a hepatic specific contrast agent.
This contrast agent is available in India, as you said. How much difference would the price be?
Yeah, we have it available in our city. We are doing it in Calcutta as well. Exactly, we are doing it HSA, which is called multi-hens is a contrast which is used exactly. And the property of it is basically, it is taken by a particular, channel in the hepatocytes only exactly. It is not taken up by the hepatocellular carcinoma or in a high-grade dysplastic nodule. So you have among all the agents, if you see, I can't show you my video exactly. There's a slide which I can show you the pickup rate of different technique using different contrasts exactly, using CT as well as MR. It has been shown that it picks up quite early compared to both CT and MR using conventional contrast agents.
Manoj, I need to ask you one thing. We frequently read in all the journals and everything something called contrast ultrasonography. So contrast enhanced USG. So what is the situation in India presently regarding contrast USG? They say it's rarely available in United States.
Manoj. No, contrast USG Sonozit, what it is called actually, it is very difficult to get in our country right now. Exactly, we had some centers are able to procure it. It's not easily available. But there are issues with Sonozit exactly. There are some issues with Sonozit, and it is not as sensitive as they say. Yeah, as a screening test or as a complementary test versus like what happens. Suppose if you don't have raised alpha fetoprotein, you have a focal lesion which is not showing classical change in one modality. So you need to confirm either doing a biopsy or you do another complementary modality, which is either a triphasic CT, triphasic MR, or you do a Sonozit contrast in ultrasound. These three are they're complementary tests. They support each other. So if you can, even if you don't have classical finding, if you can prove in another modality showing a similar kind of a classical pattern, which is typically arterial phase hyperenhancement, washout in the portal phase. These are the two criteria. And the third criteria is important, is present of capsule exactly. So these two of these criteria needs to be present to call it a hepatocellular carcinoma. This is similar
to that in CT scan. So what is the contrast you use? You use an IV contrast, just like in CT scan.
It is a IV contrast only, but its properties are different. This contrast, it has the capability of being picked up by hepatocytes specifically. Other agents, which are basically extracellular contrast agents, they don't go into the hepatocyte. They remain only in the vascular space. But this particular contrast is picked up by a normal hepatocyte, but not by an abnormal hepatocyte. This is how you differentiate.
Can I make a comment, Manoj?
Yeah.
Hello.
Yes, please.
Can I make a comment? Because for the viewers, I think those who are listening, because this contrast ultrasound is not available at the moment. So, whom do you prefer as a first line of investigation? Contrast CT and or contrast MR with the hepatic contrast? Manoj, please.
Yeah. Now, if you compare CT with MR, I think MR will stand first compared to CT exactly, for the simple reason that especially the newer generation MR which are coming, not with the conventional MRs exactly.
Okay.
Last 2 years, when we have very faster studies, scans available where we can do very thin section studies, it is possible that MR should be the first modality. But as of now, whatever we have in the market, except for few centers, most of them don't have this high-end MRs exactly.
Okay.
So there, getting a proper, technically properly done scan will be an issue exactly. In that situation, contrast intensity will be more easily available and can be done at most of the places.
I think this is the message I want to say to the viewers also. Since it is widely available as a triple phase CT rather than a new generation MR, I think that will be the investigation of choice till now. As of then we can, if there is a doubt, then we can go for the MR, contrast MR.
Yes, I have one question for Manoj. We, as Dr. Ghosh rightly pointed out, plenty of situations we have got a raised creatinine. In that situation, what would you suggest?
I think MR can be done up to, maybe up to GFR value of around 35, 40. We can easily do MR safely.
Okay.
Vis-a-vis doing a CT where the GFR has to be more than 60, ideally.
So what about the VisiPack? VisiPack can be used.
VisiPack can be used, but VisiPack contrast enhancement is not as good as the other contrasts exactly. So there is an issue with that. So if you have an issue with raised creatinine or altered function, then I think MR should be used. Exactly.
Okay.
In fact, plain MR also can give a lot of information which you may not get even on without non-contrast. MR is better than doing a non-contrast CT or just
Excuse me. Sorry to interrupt, Dr. Mukherjee. Probably Dr. Akash Shukla is ready now. So if the Sunil is giving the signal, then yes, Akash.
Hi, sir. Good evening, and sincerely apologies for.
No, it's not that. You had your commitment, and we are so happy. And on behalf of Gemas, I welcome you for this master class. And that is okay. So Dr. Mukherjee, Jayant Mukherjee is my colleague. So he will introduce you, and then we will start. You can start your presentation. Okay, please, Dr. Mukherjee, please.
Good evening, Dr. Shukla. Nice to have you with us. Dr. Shukla, Akash Shukla is the professor and head of the Department of Gastroenterology of Seth GSMC and KEM Hospital, Mumbai. He is a consultant hepatologist and transplant physician attached to Global Hospitals Parel and a joint secretary of the Zonal Transplant Coordination Committee in Bombay and head of the Scientific Committee Gastroenterology Research Society in Mumbai. He is a very well-known gastroenterologist in Mumbai, and he'll becoming a well-known in Calcutta too. So may I ask Dr. Shukla to please start with his lecture. Dr. Shukla, please.
Thank you, sir. Thank you for those kind words of introduction. Without much ado, I'll straight away go to the case. This is a 57-year-old gentleman who actually is a single doctor. And he was detected to have hepatitis C in 1993, was not treated for that. In 2007, he had hepatitis E. In 2007, when he had hepatitis E, he was also found to be HbSAg positive with a high viral load and E antigen negative. Was acute Hep B. His IgM anticore antibody was also positive, and which he spontaneously cleared. He remained total anticore antibody positive as expected. He was genotype 1 with a high viral load, and he had pedal edema in 2010, did not have any ascites and no other hepatic decompensation, a good performance status. So this patient then came for a routine ultrasound which showed a nodule, and a scan was done, as you can see here, which showed multiple lesions in the right lobe of the liver, which had enhancement during the arterial phase, and in the venous phase you can see the washout. So the enhancement in the arterial phase and washout during the venous phase. So multiple lesions with right branch of portal vein tumoral thrombosis. Now, his alpha fetoprotein was 28.9. The liver enzymes were just 1.5 times. The rest of the LFT was normal. Platelet count was 157. AFP was 28.9, and endoscopy showed 2 small esophageal varices. Now, this patient underwent a biopsy, not at our center, but he had actually come to us with a liver biopsy, and that was suggestive of HCC. This brings us to an important question. Whom do we keep for surveillance for hepatocellular carcinoma? Patients who have cirrhosis in child A and child B, patients who are child C cirrhosis who are awaiting liver transplantation, patients who are at intermediate or high risk of HCC, or patients with Hep B who have age of more than 40 years or have had significantly high viral load for a long period of time and are above the age of 40 years. For those who are non-cirrhotic F3 patients, again, even if they're not cirrhosis, F3 itself can be considered to be one of the indications for surveillance. How do we do the surveillance? We usually will do a combination of a dedicated ultrasound of the liver, where we ask the sonologist to look at all the segments of the liver and not just do a full abdominal ultrasound, and alpha fetoprotein every 6 months. Interestingly, the Asia Pacific Association suggests that you individualize the surveillance for HBV according to the financial situation of the institute, of the society, as well as of the individual patient. So that brings us to diagnosis of HCC, because here in our patient, a liver biopsy was done, and the diagnosis of HCC in cirrhotic patient can be either on the basis of non-invasive criteria or on the basis of pathology, or a combination of the two. For non-cirrhotic patients, the diagnosis of HCC should almost always be confirmed by pathology, that is, on biopsy. Whom can you apply the non-invasive criteria that we just discussed? The non-invasive criteria can be applied if the nodule is more than 1 centimeter size and in patients who have cirrhosis. For other group of patients, non-invasive criteria is not specific enough. And what are the features? They were just being discussed before I started my talk. That is the arterial phase enhancement of the lesion with washout in the portal phase or the delayed phase, or now that we are using the hepatocellular contrast agents, a delayed washout is very, very important. For those patients who have significant renal dysfunction, we are now becoming more and more used to using contrast-enhanced ultrasound for the diagnosis. What we use today is the Lyraid's criteria for diagnosis of HCC, and whether based on 5 parameters: washout, capsules, presence or absence of capsule, threshold growth, size of the lesion, and presence of arterial enhancement or absence defines whether the person is in Lyraid's 3, 4, or 5. That is probable, likely, and definitive HCC. And of course, there are variations for the same. So today, the standard of care for reporting of a CT scan or an MR for a liver tumor has to have the Lyraid's classification. Without that, it's incomplete. So the diagnostic algorithm that we have today is you look at mass or a nodule in the liver during imaging in the presence of liver disease. If it is less than 1 centimeter size, you put this person on surveillance with repeated ultrasounds. Now, different guidelines will tell you different intervals. Some say 3 months, 4 months, 6 months, but somewhere between 3 to 6 months, this ultrasound should be repeated. If it is stable, you keep on repeating. If it is increasing in size, then you go ahead with a cross-sectional imaging using a multiphasic contrast CT or a multiphasic contrast MRI or a gadoxate enhanced MRI. We are used to using BOPTA. So if the nodule is more than 1 centimeter size, we need to do a cross-sectional imaging, a properly done CT or an MRI. If there is a classical non-invasive feature which is present, then you make a diagnosis of HCC. Alpha fetoprotein more than 400 in conjunction with the imaging is almost pathognomonic. If you do not get the classical features of HCC, then you would use a complementary imaging modality. So if you've used CT for the first time, you'll use an MR or vice versa. And if one of them is confirmed or conforming to HCC criteria, then you make a diagnosis. However, if you don't, and if you find that there is still some suspicion that this could be HCC, then you would go ahead and biopsy to either rule out HCC or to confirm that this is HCC or a non-HCC malignancy. Now, this is very important because uh, only for those which are indeterminate, you will do a biopsy. So today in our practice, only a very small proportion of patients actually require biopsy for the diagnosis or exclusion of diagnosis of HCC. Typically, you will see different morphological patterns of hepatocellular carcinoma. This is the typical large HCC seen on an MRI. This is how a typical small HCC looks on a CT with arterial phase enhancement and a washout. You can see here. Very often you'll have multifocal disease, and you can see that you cannot measure the number of nodules when they are such ill-defined. You cannot measure their diameter. Whereas these are the nodules which you can easily measure. And we'll learn the importance of this when we talk of resist 1.1 and M resist. Then sometimes you will have hypovascular HCCs, which is why the multiphasic CT scan becomes important. There's not much of arterial enhancement, but there is a significant washout during the portal venous phase. So these are the tumors which have both diagnostic and therapeutic implications because they will not fulfill the classical criteria. Very often we'll end up biopsying these tumors if their AFP is not high. And these are the ones who do not respond very well to interventions like TACE. And what we end up doing for them is, if curative therapies are not possible, then systemic therapies. Our patient had tumoral thrombosis. Now today, the classification of tumoral portal vein thrombosis has become far more relevant than before, especially when we are offering curative therapies to our patient. So depending on which order branch of portal vein is involved, you classify it as VP4, 3, 2, and 1. VP4 is for the main portal vein tumoral thrombosis. VP3 is only it is restricted to the right or the left branch of portal vein. If it is the second order branches, then it is VP2, and third order branches or beyond becomes VP1. This is very relevant because today we can offer curative branches for patients up to VP3, and I'll come to that in some time. So let's come back to our patient. Compensated cirrhosis with multifocal HCC in the right lobe with branch tumoral portal vein thrombosis. What are the therapeutic options that we have? And right now, remember that we are in 2009. We are not in 2020. Would you offer sorafenib? Would you offer liver resection? Would you offer TACE? Would you offer transplant? Or you'll counsel for just supportive care? So at this stage, I would just request any of the panelists if they want to take up what would they offer to their patient at this stage.
Sharaddat Mukherjee, please.
Oh, multifocal. I just need to one more thing. There, how many lesions were there in the beginning? Were there, because I couldn't. I'm using just a smartphone, not a laptop. I couldn't see the scans that very clearly.
So around
and slides
8
just
to 9.
went by.
Around 8 to 9.
8 to 9. So, 8 to 9 is a lot of tumors are there. So in 2009, I just don't recall in 2009 whether the surgeons were that competent at that time. Even now, if there are 8 to 9 tumors, partial resection or hepatectomy might not be that possible. There is a partial portal vein thrombosis on the right side, as we have said. So in that case, I think loco-regional therapy would be appropriate for this patient at this moment of time, rather than going ahead with sorafenib or just for supportive care. So,
Yeah, I would completely agree with you.
yeah, trans
Yeah, yeah,
arterial,
I would completely agree with you. Yes,
or
arterial
rather,
radioembolization.
I will go for a combo. Say a TACE followed by an RF would be fantastic, depending on, because once a TACE is done, the RF gets even more better so far as the response is concerned. So, if given my choice, I would have gone ahead with a TACE to begin with, and then a repeat scan to see what's the uptake. If there is no uptake, that's fantastic. If there is still some uptake, I will consider RF for the further lesions. Dr.
So
Shukla.
thank you, Dr. Sharadwat. I would completely
Yeah.
agree that this is a patient in 2009 who would have probably gone for loco-regional therapy as the therapy of choice. Sorafenib had just come in, and the long-term outcomes were, we knew at that time also, was not great. So you would look at something which was better than just sorafenib. And loco-regional therapy, the options in general are ablative therapies or embolization techniques, which will include either TACE or TARE. So when you have multiple lesions like this, ablative techniques are usually not preferred. So you're left with embolization techniques, out of which you have two, either chemoembolization or radioembolization. Now, the problem with chemoembolization in such a case is uh, there is a portal vein thrombosis, the right branch portal vein thrombosis, and therefore you cut off the arterial supply as well, and you already have no portal venous supply. There is an increased risk of hepatic infarct and abscess formation, and therefore it is usually not preferred. So the second best option would be radioembolization. Cost is a major concern for radioembolization, but in such cases, that actually becomes the best treatment of choice. Probably today, if this patient had come, we would have thought of resection, and we'll just discuss that a little while later. And we'll bring in the surgeons as well, and we'll discuss why we did not consider transplant in the presence of multifocal tumor. Unless we are sure of the tumor biology, uh, I don't think thinking of transplant would be appropriate at this stage. So in this patient, the hepatitis B did not require any management, and the management of hep C was deferred because the treatment of the HCC was thought to be a priority at that stage. And remember that again in 2009 we did not have DAs, so the treatment would have been pegylated interferon, so which would have been extremely impossible to give at this stage. So this patient actually underwent transarterial radioembolization, as Dr. Sharadwat just mentioned, and in the month of August 2010. And this is the image after the radioembolization. You can see that there was hardly any arterial enhancement. In fact, there was no arterial enhancement after this, except for one particular corner. The AFP after 3 months was elevated 64.6. There was a 1.9 centimeter segment left, which was enhancing and which had a washout. So the question was again, what do we do? So out of all the nodules, there was only one area which had a 1.9 centimeter segment in the segment 8, which was enhancing. So again, we were left with three options: radiofrequency ablation, resection, or now do a TACE. Remember, at this stage, the portal vein had also responded. So the portal vein has opened up. The lesions have responded. There is one particular area which is just showing the enhancement. So can we have somebody from the panel comment on what they would offer at this stage? Probably an interventional radiologist would be a very good person to comment upon.
Dr. Jain, please.
I think RFA ablation model, what would the first option is because it's very difficult to embolize once it is already embolized care has been done. Picking up that vessel which is supplying that focus will be very difficult. So I think first options would be ablation, RFA or microwave, whatever you call it.
Yeah, I completely agree with you. And absolutely the same logic. we would have thought of resection today, but again, at that time, we were not so confident about resecting, and there was not much evidence for multicentric lesion with portal vein thrombosis getting resected. So at that stage, this patient did undergo radiofrequency ablation, and there was a complete response, which is not unusual for tumor size which are less than 3 centimeters. Uh, if the lesion is at is at a favorable location, then a radiofrequency ablation can be curative for lesions up to 3 centimeter size. For even for unfavorable locations, we now know with appropriate techniques we can safely radioablate them. Even for subcapsular location, we have techniques now to ablate for patients which are next to large vessels, tumors which are next to large vessels. Now we are very comfortable, inflating the balloon and stopping the venous flow, and then carrying out the ablations to prevent the heat sink effect. So today, almost except for a rare tumor which is compressing upon the bile duct or the gallbladder or the intestines, where even today we can offer techniques to sort of protect these organs. But by and large, for majority of them, we are now able to safely do the radiofrequency ablation. That brings us to a very important question. How do you assess the response to whatever therapy we have done? Is it what we have been following for oncology in general, that is the RESIST and the RESIST 1.1, or we need to look at something else when we define response for patients with HCC? And we have all been treating all sorts of tumors and not necessarily only liver. We treat other tumors in the GI tract, and many of us are maybe treating other tumors as well. So where we follow the RESIST or the RESIST 1.1. In HCC, we follow what is the M-RESIST. And what is the difference between the two? In RESIST 1.1, complete response is defined as disappearance of all target lesions. Now remember, in HCC, this almost never happens. You'll almost never have disappearance of a lesion. What you get is disappearance of any intratumoral arterial enhancement in the lesions that have been targeted. And that is what defines complete response. Partial response is more than 30% decrease in the sum of the longest diameters of the arterially enhancing lesions as compared to the baseline. And progressive disease is more than 20% increase in the sum of the longest diameters of the arterially enhancing lesions. And stable disease is something between the partial response and the progressive disease. So today, for our response, we have to follow the M-RESIST. That's why in our scan, you saw that the tumor was actually big, but it was only a small segment which was left behind, which after ablation has become completely non-enhancing, and that's why we are saying it is complete response. To make you understand what do we mean, this is a lesion which is being treated, and you can see on my left, according to the RESIST, you will say that this patient has not responded at all because the diameter still remains the same. Whereas according to the M-RESIST, it's only the green line which is the viable part of the tumor, and you'll say, okay, this patient has a partial response. So this is how you have to change your understanding and defining response. It is not disappearance of the tumor, but actually how much is the enhancing segment. Because patients will come back and say that my tumor was 8 centimeter, it is still 8 centimeter, and you're saying my lesion has responded, where the tumor is still seen. So even before they go for the scan, we have to counsel the patients that the lesion will be seen. What we are interested in is how much of it is alive. And that is where the M-RESIST criteria becomes extremely important. So a year later, this patient continues to have complete response. AFP remains normal. At this stage, we decide to treat him for hepatitis C, which is given for 6 months. In October of the same year, 6 months later, again, no residual enhancing lesions, but in March 2013, that's almost 2 years later, after he has achieved his SVR, a residual lesion is noted on CT in the right lobe along the zone of ablation, which is 2 centimeter and oblong shaped. So at this stage, what would you do? TACE, tear, RFA, transplant, or something else? Dr. Ramdeep, would you like to take? You've been very quiet so far.
I'm just wondering whether resection is among the options or not.
That's why I asked you.
Yeah, so I was okay with resection at almost every step, except for the fact that you mentioned that there were varices. So although your platelet count was good, so I don't know, without an HVPG study, we probably would not have been able to go ahead with resection. So except for that one point that you mentioned, varices, we would have been okay with resection at every point of time.
So I'll add that here now, since I knew that that's Dr. Ray's hands were itching for the resection.
No, they're itching for
Very
transplant
important.
actually.
Very importantly, yeah.
One thing about resection is that the patient already had varices, which I have said. So that's one of the reasons, one of the points in favor of having a portal hypertension. So a partial hepatectomy in the background of a portal hypertension with a person who has already hepatitis B and hepatitis C, background liver condition, although good, the future liver remnant would be a big question, and the existence of portal hypertension evidenced by the presence of varices will be also a question which you take up, because resection can be done. Why we guys don't favor resection in many cases is just because there is a very high percentage of recurrence rates as well. That should be taken care of.
So all the points are valid and well taken. In patients with portal hypertension, we are worried about the consequences, as Dr. Ray and Dr. Sharadwat, both of them pointed out that portal hypertension makes you worried. At the same time, we also now know that in expert hands, just the presence of portal hypertension is no longer an absolute contraindication to resection. And I'll be talking about extending the boundaries for resection in a short while. But yes, by and large, conventionally, presence of significant portal hypertension is considered to be a general contraindication for a major hepatectomy. When you're talking of a minor non-anatomical resection, it may not be a complete contraindication. When you're doing, let's say, a left lateral segmentectomy, probably, again, it is not an absolute contraindication. But when you're doing a major hepatic resection, you would be worried about presence of portal hypertension. Again, here is a patient who is well compensated, child acirrhotic, who has withstood several sessions of embolizations over the last 4 years of period. So this is what makes us more confident to offer resection to the patient at this point of time. Usually, whenever we are in a doubt whether a patient can withstand the resection or not, we often will subject them to embolization, aggressive embolization, and see whether they decompensate with that or not. It's almost like the stress test of the liver. And depending on what is the outcome, we will, of course, so we do ICG clearance here routinely. We will measure the HVPG in almost all the cases who have some evidence of portal hypertension before we think of doing the resection. So as very aptly pointed out by Dr. Ray and Dr. Sharadwat both, so we will have to be very careful. We would do an HVPG, we would do an ICG clearance, we will calculate the FLR, the future liver remnant, and in the presence of cirrhosis, it should be at least more than 40%. At times, you want it to be even more if there is significant portal hypertension. So, keeping all that in mind, in this patient, we actually went ahead and did a right hepatectomy in 2013. He had a recurrent lesion in the left lobe, which was 1.8 centimeter size in February 2014. Now what? We did a repeat RFA at this stage for the left lobe lesion. CT abdomen in 2014 May showed a complete response, and there was a recurrence of lesion, again 2 centimeter size, and he again had a RF radiofrequency ablation, which was done. And at this stage, we finally told him that this is endless. It is just at one point of time you will develop liver failure, and it is high time that you consider for transplant. He was a single himself being a doctor, he was a single person without any family, staying alone, and he was very reluctant to undergo transplant right from the beginning, for the simple reason that he thought that there was nobody else to take care of him when he was, for as a part of the transplant, post-transplant care, and that is what made him very reluctant. But at this stage, he finally agreed. We were also, after the resection, pretty confident about listing him because this appeared to be a good tumor biology. It has gone on for almost 5 years now without any extra hepatic disease, without recurrence of the tumor in the portal vein. And that is what encouraged us to think of transplanting this patient. So, of course, today we will not probably wait for 4 years. We will probably, if 1 year or 1.5 years has gone well, we would be happy to transplant somebody like this. So in 2015, we again got a lesion which was 1.2 by 1.1 centimeter and a segment 3 lesion which was 9 millimeter size, which showed T2 hyperintensity. So this patient again had one RFA for the lesion which was 1.2 by 1.1 centimeter size, and we just injected alcohol in the other lesion. Finally underwent a deceased donor liver transplantation on 13th August 2015. And anybody would want to comment on the course so far and predict the outcome of this patient? Anybody? What you would have agreed with
One
the...
thing, one thing I would want to highlight for the listeners, what Dr. Shukla just now showed with this case is a too good example, is a very nice example of bridge therapy. So what he did during this intervening period, while the patient was himself a doctor who is a single person and who had no one to take care of him. So it's a worrying situation, no doubt. But what Dr. Shukla did, he just did an excellent bridge therapy while the patient was in the wait list for the transplant.
Yeah. Anybody? Any other comments so far?
Yeah, I would like to make a comment on. I think he was on antiviral therapy anyway over the long period, but because he is having so many episodes of this, recurrences of his tumor. Was he on and started on antiviral anyway?
Excellent question. So for his hepatitis B, it was acute hepatitis B in 2007, which is cleared spontaneously. So he was not put on any therapy for hepatitis B. For hepatitis C, he did receive the therapy after the complete response, and he achieved the sustained virological response. So he did receive pegylated interferon, which he tolerated, and he cleared the virus completely. So he was not on any long-term antiviral therapy. It was he got cured of both hepatitis B and hepatitis C. Hepatitis B spontaneously almost 8 years ago, and hepatitis C with pegylated interferon and ribavirin therapy 3 years ago.
I think he was really fortunate to clear the hepatitis B spontaneously.
Yeah, it was acute hepatitis B.
So it was acute hepatitis B.
Acute hepatitis B.
Okay. Thank you very much.
Okay. So this patient had actually a recurrence of multiple nodules in the liver within a few months after the transplant.
The best food I have made.
So AFP was, of course, normal. So how would you approach? Any one of you, Dr. Ramdeep, you want to take this?
Again, we need to we would have to evaluate. And when do you think was the recurrence? Was an early recurrence after transplant?
So he had multiple nodules seen on the liver, which was enhancing and which were showing washout. This was around at the routine 6-month scan MR of the liver.
Yeah, so he's been unfortunate. But I think if it's a liver restricted recurrence, then obviously we'll have to chase them with some kind of an ablation.
Okay. Anybody, any other thoughts?
Very unfortunate. Within 6 months, there's a recurrence. So my money is with ablation, obviously, or any local regional therapy.
So would any one of you think of a biopsy in this patient?
Yeah, I will very much.
Yeah, Dr. Ray also agrees.
Yeah.
So all the panelists are agreeing that this patient, we would do a biopsy.
Yes.
and that is,
Yeah.
I think, very, very
Because
wise.
not
Yeah.
because of the history, but because of the cadaveric transplant, we do often get, yeah. So yeah, definitely.
So
Yeah.
I think both the panelists, I would completely agree with them that we should think of doing a biopsy in this patient. And the biopsy was actually suggestive of caseating granulomas.
Great.
So,
Oh,
and
really? Thank you very
yeah,
much.
yeah.
You
So,
foxed us with using the word recurrence. So we just assumed. I think Dr.
So,
Sharad
unfortunately,
Mukherjee was thinking the same.
so you are
Yeah.
absolutely right. We were also foxed because this
so
was
now,
written on the MRI report,
Yeah.
recurrence
so
of
now
multiple.
will I have another question in Dr. Shukla? Will I have another
Sure.
question in retrospect? So, what was exactly the MRI saying or the CT saying? Did they show the classical features, or it was just as suggestive of recurrence?
No, in fact, it had shown enhancement and washout both, and that is why we
Yeah,
were. But the AFP was normal. Usually, with post-transplant recurrence, it's almost always much more
exactly.
aggressive than
The
the original
AFP.
one. So AFP normal
We
is
need to
what
have
got us.
something. Exactly. We need to speak something at least a little bit more about this alpha fetoprotein. What we see in a regular day-to-day practice, people tend to rely too much on alpha fetoprotein.
Yeah.
All the guidelines worldwide, all the literature, they do not ask us to depend blindly on alpha fetoprotein, because alpha fetoprotein might be raised in even few non-malignant conditions, in germ cell tumors, in a host of other conditions as well. A cutoff alpha fetoprotein of more than 400 nanogram per milliliter is not a big, it's a big deal. It's not that we find every day. So what we think about this is that we need to do biopsies as well. This patient can also have an intrahepatic cholangiocarcinoma.
I think you have put yourself on mute, Dr. Sharadwat.
There is to keep in mind, and we should, because nowadays the trend is that, oh, this guy is getting a biopsy done in a liver cancer. That's awful. That's not the question. We need to do a biopsy, put in a needle whenever there is a suspicion. We need to do a biopsy. Dr.
So,
Shukla.
yeah, thank you. So, to summarize what Dr. Sharadwas was trying to say is, presence of a normal AFP does not rule out hepatocellular carcinoma. So you may have a HCC and you may have a normal AFP. A mildly elevated AFP need not necessarily mean hepatocellular carcinoma. So a value of up to 20 is very much acceptable. A rising alpha fetoprotein raises immediately a suspicion that you may be dealing with hepatocellular carcinoma in a patient with cirrhosis. An alpha fetoprotein level of more than 200 or more than 400, according to some guidelines, is strongly favoring HCC and should immediately raise the suspicion that, or almost considered to be diagnostic of HCC. Do not get flummoxed in a patient who has got high alpha fetoprotein more than 400. And if the liver imaging is normal,
Normal.
do not think that there is a HCC. It may be a germ cell tumor or a testicular tumor which has not been seen. So do the imaging for those
Exactly.
lesions. So these are the points which Dr. Sharadwat raised beautifully, and I think these are very, very important take-home messages. Whenever
One
you are
more
in
thing.
a doubt, do not be afraid to do a biopsy, especially in one non-cirrhotic patients who have a lesion and in post-transplant patients. So these are the two groups of patients where we would almost always do a biopsy unless alpha fetoprotein is also high and the imaging is also classical. Then you need not do a biopsy in these two group of patients. Yes, Dr. Shilpa. Okay. So this
Also been
patient,
studied. One is DCP. We need to highlight at least there are two other markers, DCP and alpha fetoprotein 3, L3.
yes.
So,
So
but
this,
there are little value nowadays. But one thing I need to say, DCP plus AFP have been found in many literature to be of DCP and alpha fetoprotein might be even more helpful. Dr. Shukla.
Yes. So in patients where we are in diagnostic dilemmas, we would often do a DCP as well as AFP-L3. Fortunately for us, we have it commercially available in the city of Mumbai, but it pushes up the cost a lot. And also the second problem is the turnaround time is almost 3 weeks. So we have to wait for 3 weeks for these reports to become available. And therefore, in routine clinical practice, we have not found it to be very useful, and therefore we are no longer doing it routinely. Although we are doing studies where we are doing the importance of, we are assessing the importance of these, as Dr. Sharadwat just mentioned. So this patient was given antituberculous therapy for a year. As I said, he had already cleared his HbSAg and NT-CV, and 3 years post transplant, he is still doing well. This brings us to the way we approach our patients, and we have been following all these years this BCLC classification, which tells us that if it is a very early stage, do an ablation or a resection. For early stage tumors, you have options of resection, transplant, or ablation. For patients with intermediate stage, you do chemoembolization. For advanced stage, offer a systemic therapy, and terminal stage, you offer best supportive care. Now, unfortunately, this has been extremely restrictive, because what do you do with a patient who is child C cirrhosis but a 3 centimeter HCC? According to this patient just becomes eligible for best supportive care. What do you do for a patient like ours, who is a multinodular unresectable lesion? Would you just do chemoembolization and forget about it? The answer is no. You cannot give up on these patients, and therefore BCLC, though good for prognostication, is not the ideal classification to follow from the point of view of management. So is there something better that you can offer? And the answer is, today we have the Hong Kong liver cancer staging system, which is what we follow for making day-to-day decision. So based upon the tumor status, that is based upon the size, less than 5 centimeter or more than 5 centimeter, number of nodules less than 3 or more than 3, and presence or absence of intrahepatic venous invasion, you classify a tumor into early, intermediate, and locally advanced. And then you look at their child status and the performance status. So in short, if I can just give you a one very basic rule: whenever we take a decision in a patient with hepatocellular carcinoma, you look at the tumor characteristics, which includes the number, the size, the location, the vascular invasion, all the characteristics of the tumor. You look at the liver function status, which includes the child park, the MELD, presence, absence of portal hypertension. And then finally, you look at the patient as a whole, and you look at his performance status, you look at the comorbidities, you look at his non-hepatic long-term survival outcomes, and then you basically decide what is the best therapy for your patient. So it cannot be only looking at the tumor, it cannot be only looking at the liver, it cannot be only looking at the patient's comorbidities. It's the whole thing. When you look at it together, that is what decides what option is best for the patient. So in this HKLC, ECOG1, child AB, early tumor, no extrahepatic or vascular invasion, uh, resection, transplant, and ablation, all of the options. For intermediate tumors, again, resection is an option. For locally advanced tumor, resection or chemoembolization are the options. And in the presence of extrahepatic or vascular invasion, extrahepatic vascular invasion or metastasis, systemic therapy will be offered. Now, the more interesting part is on the right. In the presence of child C status, even if the person has a poor performance status, in the presence of an early tumor, liver transplantation is to be offered. This is a new category, what is called a stage 5A, where transplant is curative both for the tumor as well as for the cirrhosis. But remember, this is only for an early tumor. For intermediate or advanced tumors, in the presence of child C cirrhosis and poor performance status, best supportive care is to be offered. Does it really help the patient, or it is only for glorifying the newer treatments that we have? For that, we need to understand the key differences between the HKLC and the BCLC. So HKLC combines ECOG 0 and 1 into one category because that is what we do in our routine clinical practice. The stratification of the tumor is on the basis of size, number, and presence or absence of vascular invasion. And there are two new categories: separate classification of locally advanced tumor 3B and tumor with extrahepatic venous invasion or metastasis, that is stage 4. And there is a unique stage 5A created for transplantable early HCC associated with child C cirrhosis and ECOG 1. When patients receive treatment according to HKLC algorithm, the median survival increases to 16.6 months as compared to 8.9 months when they receive treatment according to BCLC algorithm. So this is why we should probably move towards HKLC rather than BCLC. Now, which are the patients who will benefit the most? Of the BCLC-B group of patients, who are classified as HKLC2, the survival benefit of radical therapies is substantial. The 5-year survival rate in this group, when they're treated by HKLC classification, is 52% as compared to 18.7% when treated according to BCLC. In BCLC-C patients who get reclassified as HKLC2, the 5-year survival rate is 48.6% if you treat them with aggressive radical therapies, as compared to if you treat them according to the BCLC therapies, where the survival is just 0%. That is, nobody survives for 5 years. So what is the difference in the treatment recommendation? Why this change has happened? It is because multifocal tumors or intrahepatic vascular invasion is not considered a contraindication for surgical resection. Ablation is recommended for tumors up to 5 centimeters, and that is because of better ablative techniques that are available now. The intrahepatic vascular invasion is not considered a contraindication for transarterial therapies, and more aggressive treatments give better survival outcomes provided careful patient selection is done in terms of the functional liver reserve. Now let's see, can we do hepatectomy beyond the BCLC? Can we extend the boundaries? So portal hypertension present, what is the extent of hepatectomy? Are you going to remove less than 3 segments or more than 3 segments? Similarly, if there is no portal hypertension, are you going to remove less than 3 segments or more than equal to 3 segments? So if you are going to resect in the absence of portal hypertension, less than 3 segments, and the MELD score is less than equal to 9, then there is a risk of decompensation of only 5% and a mortality related to liver of only 0.5%. If the MELD score is more than 9 with less than 3 segment resection, or if more than 3 segments are being resected, then the liver related mortality is 9% and less than 30% risk of liver decompensation. So in a patient who is not a transplant candidate for whatever reasons, this still is an acceptable risk, because the risk with any other form of therapy is much more. Now, in the presence of portal hypertension, if there is a less than 3 segment involvement, this is the same risk as a major resection in the absence of portal hypertension. So again, just presence of portal hypertension is not sufficient. But if there is a major resection which is being planned, then the liver related mortality becomes 25%. And that probably will be unacceptable for majority of the cases. Whenever we are doing hepatectomy, we would almost always prefer anatomical resection, because that is associated with a reduced risk of recurrences. The difference is not huge, but it is significant, at least in the long run. So if anatomical resection is possible and feasible and safe, it would almost always be preferred over non-anatomical. Non-anatomical would be restricted to anatomies which are not favorable for anatomical resection. We did tear for our patient, and actually that was a game changer because we did achieve recanalization of the right branch of the portal vein. And this is what Salem showed beautifully in his paper in 2017, that there is a significant improvement in survival as compared to in those who respond to tear as compared to those who do not respond to tear. So across all the BCLC stages, those patients who have a response to tear will have a much better survival, which is what was seen in our patient as well. Of course, we have now much better and curative therapies for BCLC-A, and very few patients with BCLC-C are eligible for TARE, and therefore the main benefit is for those patients who are in the intermediate according to BCLC-B. And these are the patients where TARE should be offered, and in selected patients with BCLC-C. When you compare TACE and TARE for especially for large lesions, there is a tendency towards favoring TARE over TACE simply because of the safety more than the efficacy. Although for large lesions, even the efficacy appears to matter and become significant for TARE as compared to TACE. This is extremely relevant for us. If cost is not a constraint, then quite often for large tumors, especially more than 10 centimeter size, we would prefer tear over TACE. But cost is a major limitation, and that is why it is not a favored. The other important conclusion of this meta-analysis was in the presence of PVT, there was a distinct survival benefit if we use tear as compared to TACE. Now, there are several new systemic therapies and systemic targets which are being targeted and developed. So, several of them have actually become available as well. Unfortunately, for want of time, we will not be able to go into the details of all the chemotherapies, but the SELECT trial, which introduced lenvatinib to us, showed that it was efficacious and it was safe to use and had lesser complications as compared to the existing therapies. And that is why it was a good proof of concept study that lenvatinib can be used for patients with locally advanced HCCs. In comparison to sorafenib, the survival is almost similar, 13.6 months as compared to 12.3 for locally advanced tumors, but they have better median progression-free survival, and the time to progression is also delayed. And therefore, today lenvatinib is preferred over sorafenib because of its efficacy as well as because of its much better safety profile, less incidence of hand-foot reaction. But be aware that lenvatinib has a different set of side effects, and that is proteinuria and hypertension, which we need to monitor. Remember that the majority of these side effects of hypertension and proteinuria will happen in the third and the fourth week after starting lenvatinib, and that is when the monitoring has to be at its best. These are the different drugs which are going to become available because they're in different stages of trial. If they're found to be efficacious and safe over the next 5 to 10 years, but how many of them will see the light of the day eventually, one can only guess today. So, what are my take home messages? We use lyrides for diagnosis of HCC. Alpha fetoprotein is useful but not mandatory for diagnosis of HCC. Liver biopsy is done in patients where imaging is not classical, in patients with non-cirrhotic large lesions, and post-transplant patients, or where imaging is inconclusive. HKLC staging appears to be superior to BCLC for planning therapies. M-RECIST is better for assessing response to radiological and systemic therapies. We need to be more aggressive for resection and ablative therapies. Transplant should be offered for the right candidates where it is curative. Lenvatinib is safer than sorafenib with similar efficacies. There are many new therapeutic agents which appear to be promising. We know that surveillance impacts prognosis, like in our patient, incidentally detected tumor has helped in uh, better manage early and better management of the patients. But our case highlights that a meticulous follow-up and appropriate and timely therapy, including bridge therapy, is extremely important for long-term survivals. And one of the things which we did not highlight in our case, but which is extremely relevant, was that his liver function remained very steady for all those years for us to do all the therapies that we wanted to do. The liver transplant is curative in the right patient, and the hepatologist, along with the multidisciplinary team, which includes the surgeon, the interventional radiologist, the diagnostic radiologist, the pathologist, and the ICU team, play a very, very important role in the assessment and management of patients with HCC. Thank you very much, and I'll be happy to take any questions if there are.
Thank you, Dr. Akash Shukla, for the extremely highlighted case you have presented. May I request any of the panelists to put forward the question if they have any?
May I ask a question, Professor Shukla? It's a very nice presentation. How how many cases you see a recurrence of HCC in patient after transplant, especially in cases of NASH cirrhosis?
Excellent question. So I will give you our own data and the world data. It, the outcomes or the recurrence is dependent on the criteria that you use as indication for transplant and contraindication for transplant. So we at our center follow the UCSF criteria, and with that, our recurrence rate is actually below 5%. When you look at the world literature, uh, even with the up to 7 criteria or slightly more liberal criteria, it is still within very well accepted rates of up to 7%. When you start extending the criteria, like you start using the metro ticket concept or any number, any lesions, as long as there is no macrovascular invasion or other sort of criteria, that is when you'll start seeing more recurrences. So for a given patient, you'll have to actually individually prognosticate and counsel them what is the recurrence rate for that particular patient. Because you have on one hand a patient who's got a 2 centimeter lesion with a normal AFP, his recurrence chance would be much lower than somebody who's got a 7 centimeter lesion with an AFP of 3,400. So alpha fetoprotein levels of more than 1,000, presence of macrovascular invasion, presence of multiple lesions, uh, and presence of on resected on the explant, presence of microvascular invasion are all predictors of increased risk of recurrence.
Thank you very much.
Before we end, we have got a question from the audience to possibly Dr. Manoj Jain. Basically, with the raised renal, altered renal function, whether MR contrast can also be used. Dr. Manoj Jain. Yeah, unmute, please. Please unmute yourself. Manoj, you are mute. Yes.
MR contrast can be used up to GFR of 30, 35 exactly safely. Vis-a-vis a CT contrast, which we don't use beyond 60, 50, 50. So I think MR can be used in situations where there is a mild impairment of renal function.
Well, I have one question, rather a comment rather than a question to Dr. Shukla. So far as our discussion was there regarding the loco-regional therapies, I think you have overlooked only one therapy which is now coming up like anything, that is called stereotactic radiotherapy or stereotactic body radiotherapy. So SBRT is now a thing which is an in thing, is coming really good and is climbing up the ladder. So we need to have a new look with open minds towards this, because it doesn't require any such criteria. Any tumor can be treated, and it is not as costly as TARE as well. So we need to have a look and give our thoughts to SBRT. That's one loco-regional therapy which we have not discussed at all.
I completely agree with you, and I think you have brought up a very, very valid point about SBRT. In fact, there are now definite places where we have started using SBRT. One of them is patients who have macrovascular portal vein thrombosis. There is a paper published from Medanta where they have downstaged these lesions by using SBRT and then transplanted and shown excellent outcomes. We have personally been using SBRT as well for almost last 4 years, where for many of these patients, uh, our experience is although not as good as some of the other centers in the country, but I think it is still better than TARE in quite a lot of patients where cost is a problem. We are currently doing a trial with Tata Memorial Hospital in Mumbai, where we have SBRT versus TARE, and hopefully the results will be out next year. And the other group of patients where we have found it very useful is in post-transplant patients who have, lymph node recurrence or a small area of small recurrence in the liver. In those patients also, we have found SBRT to be extremely useful. So I think, yes, you are right. SBRT is something which is for the future. It is coming up very well, and it should definitely be kept with open mind. Dr. Ray wants to make a point, I think.
Yeah, I just wanted to highlight what Dr. Sharadat brought up. That I think all transplant centers now, we have a burning need to treat every patient. There's hardly any patient whom we do not treat. And so there was a gap where patients who were not ready for TACE, who required TARE, and they cannot afford TARE, and there is a portal vein thrombus. SBRT has filled that gap. So, and most of the patients, the results are not very good because the patients that are chosen for SBRT are already quite, very selected patients have already, the other options are not there. But with rightly chosen options, probably the results won't be as bad. I think.
SBRT doesn't require any size constraint, any vascular invasion constraint. It really requires a child's A or B. Even in C, you can try, but you'll have to reduce the dosage. It's a hypofractionated radiation, which we can win in 1 or 2 days, 30 to 50 grays in 1 and 2 days, an extremely precision instrument, which is basically a radiosurgery. I can see in about 20 to 25 years, the things which we are progressing, partial hepatectomy and locoregional therapies. If we consider TACE, TARE, SBRT is soon going to become the number one in all these spheres because it is really cheap. It doesn't require that much of a cost. It is an OPD treatment. It doesn't require hospital stay. You can reduce the dose according to the liver function. If it's child's A, we can go full throttle and reduce the throttle or put down your gears if it's not as good as the liver function as in child's A. So we must consider this. The problem is in all the cases in India, go to a hepatologist or a gastroenterologist or to a surgeon. And the radiation oncologists, the clinical oncologists, the medical oncologists get to see the case when it's almost the end of the career of the tumor. So it is at that time the systemic therapy is being given. It is at that time the SBRT is being offered. So now it's the time to think, sit straight and think upright that we need to consider SBRT upfront.
So I'll just make a few comments because this is a very pertinent point. Uh, while there is good data which is emerging, I don't think it is ready for prime time yet. In patients with child C cirrhosis, we have had disastrous results with the use of SBRT, especially if we are tried to target within the liver. Yes, for targeting portal vein tumoral thrombosis, it is an excellent modality. For targeting lymph nodes post-transplant, isolated lymph node, it is an excellent modality. We still need more data before we can say that it is superior to TACE, where patient is also eligible for TACE. One more new strategy which is coming up, which is what Kudo has proposed, is use for patients with locally advanced tumors, use of lenvatinib before using ablative therapies and embolization therapies. So basically, the problem with many of these patients who have borderline liver function is the moment you embolize them, they decompensate, and then it's accelerated death for them. And therefore, for these patients, use lenvatinib, reduce the tumor burden, and then use these embolization therapies or ablative therapies as a curative modality for whatever is remnant. Now, that is again for a small number of patients, not for a large majority. So, a better use of SBRT for appropriate patients, using lenvatinib before the use of local regional therapies. This is what are the new paradigms that are evolving, and I think we should keep our minds open for these strategies. And but we definitely need more data before these become the mainstay of our therapies.
Thank you all, and I want to thank Dr. Shukla for your excellent lecture and their very good case, and covering the management of hepatocellular carcinoma in a brilliant manner. And I want to thank Dr. Jayanto Mukherjee, Dr. Sharadat Mukhopadhyay, Dr. Manoj Jain, and Dr. Ramdev Rai for their active participations. And I want to thank all the delegates for their participating in this meeting. So lastly, I request Mr. Avijit Roy, who is the general manager of NATCO Pharma, to say the final vote of thanks for this meeting. Mr. Roy, please.
Thank you, sir. Thank you, Dr. Chaudhary. Very good evening to all the doctors, and on behalf of NATCO Pharma, I, Avijit Roy, most graciously will, thank you, Gemas, especially Dr. Sujit Chaudhary, and for giving us this opportunity to get associated in this academic evening. And it's a wonderful, speech as usual. And I always appreciate Dr. Akash Shugla because of his extraordinary, knowledge, and most, appreciable is that, leaving aside all his personal commitment, always he keeps upfront towards the, professional as well as, academic cause. I, always, we are thankful to Dr. Akash Shugla for taking out his time to educate the doctor fraternity. And I, on behalf of, once again, NATCO Pharma, I, compliments moderator for doing his, excellent work for hosting this evening, as well as all the panelists, Dr. Sudipta Ghosh, Dr. Manoj Jain, Dr. Ramadip Roy, and Dr. Sharadat Mukhopadhyay for their esteemed contribution in this evening. I, graciously once again thank you for all the participant organizer for hosting this evening. And just one word I'd like to, share at the end of the, this evening, that at NATCO Pharma, always we try to bring the specialty medicine at India with very affordable cost. We did it on hepatitis C, B products, many antibiotics, oncology, and now we are exceeding our, this commitment towards NASH products, as well as, very soon we are going to extend further on IBD and IBS products, which are not available in India, that we are going to extend. Maybe we are going to start from this next December onwards. So we look forward to getting associate for such, academic evening along with Gemas. And thank you all once again, Dr. Chaudhary, and good night to all of you.
Thank you. Good night to all of you.
Good night.
Thank you, Abhijit. Thank you so
Yes,
much.
thank
Thank
you,
you, Dr.
sir.
Chaudhary.
Thank you, sir.
Thank you so much. Thank
Thank
you,
you.
all the panelists. It was really wonderful. And my apologies once again for logging in late. The previous session got delayed, unfortunately.
Thank you, sir. Thank you.
Thank you. Thank you so much.